Loud. Here we go.
Thank you so much. Welcome, everyone. This is Christy Bird McKeeve. I'm the Executive Director of Butte-Glenn Medical Society and the CEO of Healthy Rural California. And we are really excited today to have our next virtual grand rounds in partnership with Enloe Medical Center, who will be supplying the CME for this talk. A few basic things that we should know by now, but it's always good to be reminded. Please keep yourself muted unless you are speaking. The chat feature is a great way to ask questions, and we will be doing some Q&A toward the end of Dr. Milliron's presentation. We are recording this presentation, and it will be available through the Butte-Glenn Medical Society YouTube channel, which is open to the public. This particular topic, we are very excited to share far and wide as we look to promote more providers in medically assisted treatment throughout our communities. If you have any technical issues, it's easiest just to log off and log back in. That usually resolves any of the problems. And thank you again to Enloe Medical Center for the CME. There will be a follow-up email to all participants who are on the call. I'll be noting your name down and making sure we have your email in order for Enloe to follow up. After I'm done speaking, we're going to have a highlight on Enloe's new urology program, which I'm really excited to hear. I'd heard it was new, and so some good details to be shared on that. And then a quick note that we will be having our virtual opioid summit, which is always in partnership with the Butte-Glenn Opioid Safety Coalition. If you're not involved with the coalition, you should be. And that'll be September 15th. In the late day. I'm not sure yet about the start time, 4 or 5 p.m., but something that will not conflict with our busy daytime schedules. And with that, I'm going to ask Shelley to speak a little bit about Enloe's urology program.
I'm actually going to speak on behalf, but Shelley's here with us. She is our practice coordinator for urology. So if anyone has any questions after I'm done talking or at the end, me or her happy to answer any questions. But my name is Bailey. I'm a part of Enloe's community outreach team. So our goal is to connect our community with the different resources and programs available. We know things, especially with COVID, have been ever changing. So we just want to make sure that that connection's being made. Something we also deal with is referrals. So if anyone ever has any questions or issues or concerns with referrals, you can always reach out to my team. That's what we're here for. We've gotten a chance to go to all 8 counties at this point. So if you see any paperwork in your office that was Enloe that you hadn't seen before, it's probably because myself or my coworker got the chance to drop that off. And so today we're going to talk to you, like Christy said, about our newest service line, urology. Our newest service line's coming with a brand new doctor, Dr. Matthew Johnson. He is one of our newest doctors, and he's providing a full scope of urology services for men and women. He actually came to Chico from St. Louis, so he had a little bit of a distance where he served in private practice at that time. And then prior to that, he was affiliated with, I believe it's Leahy Clinic in New Hampshire and in Massachusetts. And some of the services that he provides include kidney stones, urinary incontinence, urinary tract infections, overactive bladder, erectile dysfunction, benign prostate enlargement, urinary retention, low testosterone, infertility, prostate, kidney, and bladder issues. He also does perform vasectomies and traditional and minimally invasive urologic procedures. His team includes 2 PAs, Shannon Holler-Baker and Brittany O'Regan. And we understand that our community unfortunately has been underserved in urology services for quite some time. So we're really excited that this is something to kind of open the opportunity and make sure that our community really is getting the support that it needs for its different healthcare parts. And if you do want to send a referral over to our service line that is urology, some things to keep in mind is your patient should be contacted within about 48 hours of that referral once we've triaged it. So if you hear back that that wasn't the case, then definitely let us know. Don't feel like you're bothering us. We are more than happy to make sure that things are going the way they should, because we want people to be taken care of in a timely manner. And on average, we're looking at a turnaround rate of about 2 to 3 weeks for the initial appointment. That being said, it is totally case-by-case basis. we're not going to make somebody that has an immediate issue wait weeks. So if there is anything specific, you're welcome to call and say, hey, I need somebody to come in right away. There's X, Y, and Z issues. Our team's here to make sure that people are getting the proper healthcare support. So if you do have any questions, you're more than welcome to ask them now. Me or Shelly are happy to answer them. And we'll also put our email, our community outreach, community.outreach@enloe.org email in the chat. So if you guys have any questions about this service line or a different one, you're more than welcome to reach out.
Thank you, Bailey. She did a great job. I do want to point out too, like Bailey said, based on diagnosis, we wouldn't make anyone wait for especially a kidney stone for 2 to 3 weeks. But our volume is obviously increasing because we were underserved in the community, just based on all the urologic needs are out there. So our staff is doing a fabulous job of making sure our patients are being served promptly. So if you have any questions, concerns, let us know. We are located off Cohasset, right next to the Cancer Center. So you guys are welcome to stop by and check it out. It's a beautiful new building. Well, inside. Thank you.
Right. Thank you both. So Dr. Milliron, do you want to share your screen and start presentation? Oh, thank you for sharing that, Bailey. The chat has the email. All right, thank you.
Hi, everyone. Thank you so much for having me. My name is Alyssa Miller. I'm a physician. I work at Ampla Health. I'm actually new to the community. I grew up in Oroville, but went off and did training for about 10 years and just came back. And so it's really very nice to meet everybody and an honor to be asked to share one of my favorite topics, which is opioid use disorder treatment. My goal today is to reach out to those primary care doctors who have an interest in helping their patients who have opioid use disorder, but really just don't know where to start or are afraid to do it. I was somebody who in training didn't get much training in this, and really started about 1.5 years ago doing this. And so from one recent beginner to another, I'm here to tell you that it's not that hard. It's actually much easier than a lot of the things that you do in medicine. It just takes a little bit of learning, and I think we can accomplish a lot here in the next about 40 minutes that we have together to figure out how to help your patients who have opioid use disorder. I have no financial disclosures. Other than I do work for Ampla Health, which does provide medication-assisted treatment with buprenorphine. I do not directly benefit from any referrals or anything like that, but just a disclosure. So our objectives today, as I said, is to understand the need for opioid use disorder treatment in Butte and Glenn counties, understand the diagnosis and treatment options for opioid use disorder, learn how to start someone on buprenorphine, which is known as an induction, know the resources in Butte and Glenn counties for patients with opioid use disorder, and learn how to get an Axe Waiver, which is still required, but we'll talk about that, about the changes in those requirements. So the prompting for this was that prior to 2021, medical providers were required to take a training course to prescribe the combination buprenorphine naloxone. For physicians, this was an 8-hour course. For NPs and PAs, I believe it was a 48-hour course or something like that. It's somewhere in the 24 to 48-hour range, but quite a cumbersome requirement. And as a result of that, you all know this very well. You're very busy people. You don't have time to do a lot of these trainings and to get the support you need. And therefore, we have limited providers who can do these services. The 2020 was a very difficult year. We had a lot of relapses, even on people that had previously been stable in treatment. And we also had a lot of we had a lot of overdose deaths, and so we started looking into what can we do to expand services. And the consensus was that we should lower the requirements to prescribe Suboxone or buprenorphine naloxone, so that in rural regions, people can prescribe, and at least get people help. Um, this this was also with the understanding that prescribing these things is not that hard. We allow new trainees right out of medical training to prescribe Norco, morphine, oxycodone, but we don't teach them how to prescribe buprenorphine. And in fact, we put barriers up to it. And so this is hopefully the beginning of us transitioning to um, a more a more equitable training in addiction care for trainees, and hopefully allowing that to be just part of being general medical education. Why does this matter? Opioid overdoses are preventable deaths. We in 2019 here in Butte County had 12 deaths. This was lower than it had been in prior years, but really any of these are preventable deaths. These are unnecessary deaths. We have excellent treatments for people, even if they are still continuing to use to help protect them from overdosing. The drug supply in this area is contaminated with fentanyl and ecstasy. There is no way for somebody to know that they are safely using drugs. And we have the ability to capture patients who have been neglected by the healthcare system. I'm not going to spend too much time on the diagnosis of opioid use disorder. We have a lot to cover today, but I want to direct you. This is the DSM criteria for opioid use disorder. Um, Usually it is pretty easy to tell if somebody comes to you and says they're actively using heroin and tells you the story of how they started. It's pretty clear that they have opioid use disorder. What I would caution you on is that there are people who have complex opioid dependence who, if you go through these criteria, they actually do not meet opioid use disorder criteria. Um, so when you are in the room with a patient and you are not sure, just pull this up on your computer and start asking them the questions and see if they meet 2 or 3 of these, they have opioid use disorder. And so the substances used in opioid use disorder that we see frequently here, heroin, fentanyl, prescription opioids, Kratom, which may be a new something that many of you have not heard of. Kratom is actually something you can buy in smoke shops and in gas stations here in our county. Um, it is likely going to be banned at some point here, but for right now is available for people to buy. You will hear many patients say to you, I used to be addicted to pills, but now I'm better because I have Kratom. And they do not believe that it is a dependence or a problem, because, of course, you being able to buy it at a gas station feels like it's something that should be safe. We do if for people that have kratom opioid use disorder, we still treat them the same as we treat people who use heroin, fentanyl, that kind of thing. And then I put other synthetic opioids here. We are finding every day that there are new things that our patients are trying that have opioid properties. So just be very, I think the question that I want to ask people is there something that you take every day that if you do not take it, you feel sick? You will get a lot of interesting answers of things that you've probably never heard of, but when you look them up, you find out that they are synthetic opioids of some sort. So this is just, we're going to do a quick review of buprenorphine basics here, so that you can understand how we induct somebody. So buprenorphine is a partial agonist with high affinity. And it's these properties that make it a wonderful treatment medication for opioid use disorder. So a full agonist is something that when it attaches to a receptor causes a full effect. Methadone is one of these, but the things like heroin, fentanyl, um, prescription opioids, those are all full agonists. Buprenorphine is a partial agonist, which means it has a limited effect. But when we mean limited effect, it actually has a limited effect in the ways that we want it to. For example, things like respiratory depression or not being able to breathe well, um, sedation, things like that. So it actually causes less of these things. It has a ceiling effect. But in terms of cravings and analgesia and all those kinds of things, it actually feels like a full agonist to patients. It actually does the same. It also has a ceiling effect in terms of the euphoria. So when we think about people who are very, very susceptible to addiction because of that euphoria feeling they get from full agonists, buprenorphine protects them from that because more does not create more of that good feeling. And then naltrexone or naloxone is the shorter acting version, is an antagonist, which means it blocks off the receptor, just as it shows here. And so this is why when people have opioid use disorder, we give them Narcan or naloxone nasal spray, because they spray that in the nose and for a couple of minutes they wake up and it has kicked off whatever substance they were using and overdosed on. It kicks it off of the receptors. And also feel free to stop me and ask questions if you do. I know we have a small group today, so I'm happy to answer questions on the spot. So just a few more basics on this. So buprenorphine comes in two different forms. It comes by itself and it comes in combination with naloxone. These medications are prescribed for both pain and opioid use disorder. We are focusing mostly on opioid use disorder in this talk, but you will find that a lot of people started taking opioids because they were in pain. So you have to be able to understand how to treat them both. Buprenorphine naloxone is a combination medication that's used to treat opioid use disorder, and it's really for those that are at risk of injecting drugs or diverting them. So what happens is that these are both sublingual films. So you put them under the tongue and you get the buprenorphine into your system. The naloxone part of it is actually inactive in the sublingual form. So when you put it under the tongue and take it correctly, the naloxone doesn't do anything. The reason that it's there is that if you were to melt down that film to try to inject it, which buprenorphine by itself injected does create a little bit of a high, if you were to try to do that, it would actually induce a withdrawal. And patients describe it as the worst withdrawal they've ever had, like 60 to 90 minutes of it. So what this does is that it discourages people from using it in ways that could cause that high feeling. It actually encourages people to use it correctly. Dosing for opioid use disorder is typically once daily. You will see some people on twice daily, but that's about as frequent as we do it for opioid use disorder. For chronic pain management, we actually will dose it every 6 to 12 hours because we find that the pain relief part of it doesn't last 24 hours. So when we're talking to patients about why they're using opioids and their opioid use disorder, you do want to figure out if part of the reason why they're on opioids is for chronic pain, because that'll help us better dose them. So practicing your buprenorphine spiel. So you're sitting down with a patient, you've diagnosed opioid use disorder, you've gotten their history, and now your job is to convince them that this is going to be a good therapy for them. So here are some of the talking points I use when discussing with patients. Um, so a lot of the things we've already discussed. It can be used for those with prior addiction histories who have chronic pain and either have opioid use disorder or are at very high risk of opioid use disorder because of some of those properties we talked about where the euphoria, there's a ceiling on that. You can prevent deaths from intentional or unintentional heroin or fentanyl use. This is very scary to our drug using population. A lot of them have lost people because they didn't know there was fentanyl in their supply. And so this is a really important thing to talk about. This is also a better lifelong pain medication for those who are elderly, frail, or those with organ failure. This is a completely different talk that I've given before about chronic pain as a first line agent, but it's something to consider for people that you're worried about giving full dose agonists to, that buprenorphine is actually an excellent option for those people. So we have already covered all of this, so I'm actually going to skip on, except to point out that the only risks of buprenorphine therapy, when combined with other sedatives, it still does have an increased risk of death, just like full agonists. So if you were to combine it with alcohol or benzodiazepines, we still do see an increased risk of death. We have not had studies that have compared full agonists versus buprenorphine with sedatives. But based on what we know about the mechanism, we assume that buprenorphine is still a safer option because of that sealing effect. And then the only other thing that you need to know is that in moderate to severe liver failure, we have to watch people on buprenorphine pretty carefully, because there is some hepatic clearance. And so that's something to keep in mind. And people that have cirrhosis, that might be a time for you to refer that person to somebody who does buprenorphine more frequently. So getting somebody started on buprenorphine, here's the spiel. You need to stop taking all opioids 24 hours prior to starting buprenorphine. This is very, very challenging for people, but because we don't know what is in people's pills, and often they don't always know what is in their pills, we ask for 24 hours. With giving them medications such as Zofran and things like that to help with those withdrawal symptoms and make it easier on them. Um, Urine drug screening, when we do it in office, is not meant to be punitive. It actually allows us to do a better induction, and it allows us to celebrate when people really are in their recovery. And so I like to say that up front before we get into inductions. This is during your first visit. You've diagnosed opioid use disorder. You're planning that induction. Just throw it out there for people. This is not meant to be punitive. This really is so that we can better help you. So this talk is about who can we safely induct as beginner primary care doctors doing inductions. And these are the people that I would say you should not do an induction on. These are people that you should refer or you should send to Enloe, and we'll talk about that. Anybody who has methadone use, either intentionally or unintentionally. Methadone is very challenging to transition to buprenorphine in a primary care clinic. And so you want to send them to either a program that does MAT on a regular basis, or get help elsewhere. Intentional fentanyl use. There are people in our county who use fentanyl by itself, not laced in their heroin, but just straight fentanyl. These people can be challenging to do inductions on. And so I would recommend that you send those people to one of the programs that I'm going to list later for help. I would also say that second and third trimester pregnancy is one where I would send them to maybe a more experienced MAP program. The only reason being that mild to moderate withdrawal symptoms in somebody who is pregnant are actually safe. If they are going into severe withdrawal, you actually start to worry about the fetus or pregnancy. And so I would recommend that you seek help for that. That's not a good beginning induction for somebody that is new to this. Okay, so this is my induction decision tree that I use for who should be inducted by you and who should you send out. And so we will go through these questions together in future slides. But let's start with, can I safely do a buprenorphine induction on this individual? We talked about those 3 reasons why you would potentially seek higher care, right? Methadone use, intentional fentanyl use, or pregnancy. Um, should the induction be done in my office or should it be done at home? And we'll talk a little bit about that. But there are people in this community who have been stably on Suboxone before and will say to you, hey, I used to take 8 twice a day and I did really well on it. Those people are actually really good candidates to induct themselves at home. They've done this before. They know what dose works. You can help guide them and follow up with them, but you don't necessarily need to bring them into your office to do that. Versus somebody who has never tried Suboxone or doesn't know what they're taking in terms of opioids. Those are people that I would recommend you bring into your office just so you can help troubleshoot. If something happens and you throw them into withdrawal or something like that, you have them there so you can help them. Then talking about what dose should I use and what program can I refer them to. Um, so this is my decision tree in graphic form for you. So talking about, is it safe to do the induction yourself? If you find out that this patient is not somebody that you feel comfortable inducting, there are great resources. The biggest of which is the Enloe Emergency Department, especially if it's something urgent where, say, somebody is in acute withdrawal in your office and they look miserable and they want to be off of it. you can send them to Enloe and get them care on the spot, and they will induct them. If, say, they come into you and they're not withdrawing, but you still need help, say they're in their third trimester of pregnancy and you're just not sure and want to get something, you want to be more comfortable in that, you can call the Enloe emergency department and have Jake, Dr. Moore, they can help you induct these folks. And so if you do feel comfortable inducting, though, just as we were saying, this whole decision of whether you decide to do clinic versus home, and then this is kind of our flow for what you would do at that point. So the different formulations, we're really only going to talk about sublingual films today, but I just want you to be aware that there are different forms of buprenorphine out there, including implants and injectable forms that are becoming more popular. But for right now, and especially for the primary care doctor's purpose of getting somebody started, you're going to be only using films. And I will share these slides so that you have these available to you if you want to reference them later. So this is the list of all the forms of buprenorphine. But if you noticed, I really put a red box around the ones that we're going to be talking about today mostly, which are these combined forms of buprenorphine naloxone. And so we'll come back to this. This is a slide that I just want you to have as a reference after this talk. This is my how to convert people onto buprenorphine. We're not going to cover this entirely today, but I want you to go down to the bottom and see this orange text here, which shows that the conversion factor for buprenorphine, the best one I can find and that my pain management colleagues have come up with, is that the morphine equivalent of 100 milligrams is about 8 milligrams of buprenorphine. So this will be useful for us because when you're trying to find a dose for somebody, you want to know how much buprenorphine you're going to need to get them comfortable. Okay, so picking your dose for induction. Heroin use is possibly the easiest induction we do. If somebody is using around 1 gram of heroin daily, you can induct them with 4 milligram films very easily, and they will do quite well. Most of them will end up needing about 8 milligrams as their first dose. In the emergency departments here at Enloe, they actually, the ED protocol, because they get people in really severe withdrawal, is to give 8 milligrams at a time. And that's because heroin use actually usually gets you to about 8 milligrams to start. So starting with 4 milligram films for your induction is easy. You will probably need 2 of them when you induct them. For pill use, you want to try to estimate how much they're using in morphine milliequivalents. This can be rather tricky if people don't know or if they are unsure what they're taking. But for morphine, we know that morphine milliequivalents of 100 milligrams goes to buprenorphine of 8 milligrams, you can pretty easily figure out what dose they're going to need. If the conversion gives you a buprenorphine dose that is in between doses, right? So we have 2, 4, and 8 are the ones we use most frequently. If when you calculate it, you get like 3 or something, or 6, I would recommend picking the lower film dose. And the reason is that you can always give them another one if they're not feeling quite right after you give them the first dose. But I would start with the lower dose. I would go lower if you end up in between doses. For Kratom use, it's really hard to quantify Kratom use, but I will tell you from experience that if people are using multiple doses or scoops a day, you can start with a 2 milligram film and go from there, and they'll usually do pretty well. Whatever dose you decide to do, so whatever film size you decide to do, you're going to order 6 of them for your induction because the patient will need to pick them up and bring them to their appointment with you. I highly recommend that you pick films instead of tablets for patients. The reason being is that a lot of these people have prior histories of using pills, and using a pill to feel better is a trigger for them. So this is why it was formulated in film form, so that it was completely different from anything they'd ever used, and it can be associated with recovery rather than with their addiction. So here is the timeline of how you would do an induction in a primary care clinic. So this is, you've had your initial evaluation, you've diagnosed them with opioid use disorder. You've decided that they're a good candidate to do an induction in your office, and you've made an induction plan with them. You've figured out what film amount you need to prescribe. And you've prescribed 6 of those to the pharmacy and said to the patient, the day before you come into me for your induction, I need you to pick these up and not take anything, but pick them up and bring them to the office that morning, first thing in the morning. The patient will arrive that next morning in your office after being off of opioids for 24 hours. They will not be feeling good. People will they'll be sweaty, their heart rate's high, they often feel nauseous, they end up having diarrhea. It's very unpleasant. So you need to be aware, if these people are coming into your office first thing in the morning, please pull them back into a nice quiet room and really try to get the process started quickly, because we do have people that if they have to wait any amount of time, really will run out of the building because they just feel so terrible and they're already afraid of doing this. Um, at that time, so you want to confirm when their last opioid use was, and try to make sure that it was around 24 hours ago. If it's not perfectly 24 hours, but they look miserable, it's going to be okay. You're going to be able to induct these people. And so you want to perform a CAL score on them, which is our opioid withdrawal score. If they're somewhere above 6 to 10, you can give your first buprenorphine film to them. Um, at that time, you're going to wait 60 minutes, give them nice quiet space just to relax, lay down. They probably didn't sleep all night. Um, Recheck the CAL score again, see where they're at. If their score is less than 6 and they're feeling good, you can send them home with their buprenorphine films with a close follow up the next day. If their CAL score is still greater than 6, meaning that they feel slightly better but not out of their withdrawal, you would give a second film at that time and repeat. So give a second film, wait 60 minutes, recheck the CAL score. The first day, you really should not exceed 16 milligrams. I would argue for most people, they feel good after about 8 milligrams. Um, if somebody has more fentanyl use or anything like that, they may need a little more than that, but typically people do pretty well with 8. Patients should not need another dose for 24 hours if they're just doing it for addiction, right? If it's just for cravings, it should be once every 24 hours. They will have the films with them though, and you can say to the patient, if you start to experience symptoms 12 hours later before bedtime, you can take another dose of the same dose that you inducted them with. You should bring them back into clinic or at least do a phone check-in the next day to see how that went, because sometimes you will need to adjust the dose the next day, but typically people do quite well. So induction troubleshooting, the thing everybody worries about, right? If they go ahead and they do this and something bad happens. So this is a scenario where a buprenorphine dose is given. Patient all of a sudden starts feeling worse. They have high blood pressure, they're sweating, they have body aches, they're vomiting. What likely happened was that the buprenorphine attaches more tightly to that receptor than any opioid can, right? And so if you give somebody buprenorphine, even though they have heroin in their system or opioids of any sort, it's going to kick it off the receptor and it's actually going to put them into withdrawal. And so you likely have precipitated withdrawal if you give them a dose and they all of a sudden feel terrible. If this happens, you need to give them 8 milligrams because at that point you're trying to fill the receptors with buprenorphine to get them feeling better. If you get up to 16 milligrams and they're still feeling really bad, give it 60 minutes. But if they're still feeling bad, I would definitely recommend that they go to the emergency department, because we may have had a situation where they had methadone in their system or something that they didn't know. And this isn't going to resolve itself very well in your office. It's going to be more challenging. And so I would recommend you get them to someplace where they can have better care. The other thing that we find is that people don't take their Suboxone correctly. And so sometimes you'll have people say, I took 8 milligrams, but it didn't really work. You want to make sure that people are taking it correctly. So no food or drink 15 minutes before. You moisten your mouth, you put it in, and absolutely no talking for 5 minutes. Got to let it absorb. After that 5 minutes, you have this chalky powder in your mouth that doesn't taste very good. Rinse and swallow it, and that should be full absorption of it. Another troubleshooting tip, patients, sometimes you'll get them inducted and they'll feel pretty good, but just get sick every time they take it. They're not having withdrawal symptoms. They're not craving. So it's clearly working, but they're just not feeling great. And most of the time we'll hear people say that they feel a little nauseous or sick every time they take it. So the most common thing we see is that people just start doing it on an empty stomach, and sometimes it just makes them feel a little queasy. So for those people, we really recommend eat your breakfast, wait 15 minutes, then take your Suboxone. Um, Sometimes we find that it's too high of a dose, that people got put on too high of a dose and they actually just need to come down a little bit and they'll feel better at that point. The other possibility is that the naloxone part of it is actually affecting them. There's big controversy about this within the medical community, but the naloxone is known to be an inactive part of it. However, we do have patients that, for whatever reason, get sick with the naloxone formulation, but when you put them on just buprenorphine, they seem to do better. So just something to keep in mind. If you really have tried the changing of the doses, you're having them eat beforehand, they're still feeling sick, that's something to consider. The other thing is that if somebody has cirrhosis, we find that the naloxone portion of it actually builds up in the blood and can be active all of a sudden. And so if somebody is getting sick after taking it, and you think that they may have liver disease, that's also something to consider. And you could also try doing straight buprenorphine for those people. So we're going to do a couple cases. I don't know how much time we have left, Christy. Do we have 8 minutes?
Yes, we do.
Okay, so I'm just going to do a couple quick cases just so we can all get a little more comfortable here. So we're going to start with the easiest one, which is a young man, history of heroin use up to 1 gram per day, wants to start treatment with buprenorphine after losing a friend to overdose. He has no medical problems and uses nothing other than heroin. So this is the interactive part of this, if anybody would like to join. But basically, what dose would you induct him with based on the information you have? And I can flip back to our slide talking about what film dose we discuss for heroin use. Does anybody want to try?
Would that be the 4 milligram film?
Yes. So 4 milligram doses are great. You will prescribe 6 of those. Tell him to not take heroin for 24 hours. Show up at your office and start the induction that way. So very good. And so this is just a reminder of what our film sizes are to try. And then he usually our people on heroin, especially if they're using a gram, will end up at 8 milligrams. They can either take 8 milligrams for the induction, and we find a lot of them do quite well if they do 8 milligrams every 12 hours for a total of 16 a day. So case number 2, middle-aged man with uncontrolled diabetes and severe diabetic neuropathy, refractory to neuropathic pain agents. He's using Norco and morphine, which he buys on the street for pain relief. Estimates he takes about 4 to 6 Norco 10s per day. He finds that he intermittently withdraws when he runs out of money and cannot purchase opioids. So the first question is, what is the diagnosis? And it's actually a trick question because I don't think I gave you enough information to determine this. However, you would think, does this guy have an opioid use disorder, right? Is this just chronic pain and he really can stop when he needs to? Or does he have a maladaptive relationship with opioids and really can't stop, right? And he's using it at this point to feel normal. if changing to buprenorphine, what formulation and dose would you give? So the first step would be to convert what he's taking into morphine milliequivalents, which I picked hydrocodone because it's an easy conversion. So if they're Norco 10s and there's 4 to 6 of them, that's about 40 to 60 milliequivalents of morphine. And what we know is that 100 of morphine is the equivalent of 8 of buprenorphine. So based on that, what dose would you think that this guy's going to end up on if you had to induct him? Anybody brave enough to guess?
Quick reminder, you have to take yourself off mute.
It's okay. If not, I'm happy to answer it. So if 40 to 60 is about half of 100. So I would say that this guy's probably going to end up on about 4 milligrams of buprenorphine total per day. However, we know that he has chronic pain, and we know that for chronic pain dosing, we tend to give it more than once a day. So I would split this guy into 2 milligrams in the morning and 2 milligrams at night and see how we do, which is exactly what his primary care doctor did for him, who is not me. Started him on 2 milligrams twice a day. He returned to clinic actually saying that he felt kind of sleepy on this, and that when he cut them in half, he actually felt better. So he took half a film in the morning, half a film at night, and was doing great, not having cravings for opioids. All right. Middle-aged woman with history of lifelong opioid use disorder with IV heroin use comes in to your office because she's having severe hip pain. She hasn't used heroin in many years. She's previously been disinterested in medication-assisted therapy. However, she recently was admitted after she took an opioid pill that she later found out to be a large dose of morphine, and then had to be intubated in the ICU. She has significant enough pain that she has trouble making it to doctor's appointments, and would really like to start buprenorphine with us. So based on this, what formulation and dose would you give? This is the more challenging of the 3 cases because she could not tell us how much she was using, right? She really doesn't know what pills she's taking. We know she has a high tolerance because she's used heroin before, but it's been many years and her opioid receptors have changed. So the question is, what dose can you start her out on safely? So these are your combined forms. And if you notice, they go down small to about 0.7 or 1.4. So you can do really small doses of buprenorphine naloxone for people that you're just not quite sure where they're going to end up. So she ended up taking 1 milligram twice a day, and it ended up working out really well for her. And the reason I highlight this case is that it's important to get a full history. People with a history of heroin use have likely their tolerance has changed and they won't be on doses that people who are actively using heroin will use. And so it's okay to start low and work up as long as you have frequent check ins and follow ups, because a lot of people will do well on 1 or 2 twice a day for chronic pain purposes. So for Butte County, here are your MAT resources. We're very fortunate here to have what we have. And please chime in if there are ones that I missed. I tried to capture all of them, but here in Butte County Behavioral Health in Oroville and Chico has wonderful resources, especially for pregnant mothers needing to get care. Ampla Health has a pretty robust substance use disorder with counseling treatment centers in both Chico and Oroville. Aegis does a lot of our methadone. However, they do have Suboxone as well. And from my understanding, for people who are having trouble getting their substance use disorder medications paid for, Aegis actually has grant funding for those people. So we occasionally will get people with private insurance that will not pay for Suboxone. Those people may be well served by Aegis because they actually have grant money for that right now. Enloe Behavioral Health is also a good resource. They take care of our private insurance folks, so they cannot take Medi-Cal. And then, of course, our Enloe Hospital Emergency Department, super appreciative to them. They will connect people to resources and are always a good backup for you if you ever need help or just need to talk to somebody if you're having trouble with an induction. So Glenn County resources, Glenn County Behavioral Health is really your go-to in terms of getting your person connected to care. And then in terms of virtual MAP programs, the ones that I've heard of are Bright Heart Health and Groups Recover Together. We used to have groups here in Chico, but they recently closed. And they unfortunately do not take Medi-Cal. However, they are centered in Reading. And so if you needed them and a patient is not a good candidate for in-person care, they could do that as well. So just a really quick how to get your Axe Waiver. So you do not need to go through training. You can actually see up to 30 people per month without training. And so this is how you would do it. So you would go to the SAMHSA, if you look in the top left-hand corner, the SAMHSA website, which is in charge of Axe waivers and controlled substance prescribing for addiction medicine. You would fill out this quick questionnaire that asks where you work, what your license, what your practitioner type, your state license, and your DEA is. The next screen will ask you how you qualify for an Axe waiver. And all you have to check is, well, for each one it's different, but basically you have to just say practice guidelines. Which means nothing, but it basically allows you to jump through the I'm just asking for 30 people waiver without training. And so what that does is that your DEA number will come back. They will send you a new DEA number that just has an X on the front of it. And when you prescribe buprenorphine naloxone combination, you have to put your Axe waiver on there in order to get it processed. If you want to learn more about pain management and opioid use disorder, these are my favorite resources. There are many ways to get your Axe waiver if you want to get the full training. I highly recommend it. ASAM does a really great one, but there are also free resources out there. The Scope of Pain online training and podcasts are excellent in terms of just getting more comfortable with pain management and opioid prescribing. And then if you're really advanced and want to be an expert, you can do the pain management fellowship through UC Davis. And then here are my references. Sorry to go a little bit over, but I'm open to questions if anybody has them.
Hey, it's Dr. Moore from the ER over to Enloe. It was an excellent presentation. Great job.
Thank you.
Super informative. And I'll just offer kind of the counterpoint. You know, this is very talking about your dosing and milliequivalents. That is so much more appropriate for the outpatient setting. But just to sort of say where we come from, we're kind of like the Wild West of treatment over there in the ED. You know, in order to roll in all of our providers, we've really had to make it more formulaic and make it very, very easy. And that's really how we've been able to capture so many patients and get our providers to treat. So number one, don't be surprised if you see patients, you know, who Jake has plugged in with you all as outpatients who come in after having maybe 8 milligrams, 16 milligrams, when ultimately they may require a lot less. So just keeping that in mind, that doesn't mean we're doing it differently. Reasoning, I think, is that we tend to overtreat mainly to help ensure that we're capturing these patients, because I think given the option, if I'm on the edge using a cow score or just even asking them how they're feeling, and they're kind of on the edge of I feel pretty good or I feel still a little withdrawal, I would always err on the side of giving them an extra dose, because we have in our favor that the ceiling and the therapeutic index is so high on this medication, it's really hard to screw up and do something horrific. They might be a little somnolent, and that can ultimately be titrated down. But the bigger fear we have is if we don't send the patients out of there feeling great, they might the next day just say that medicine didn't work for me. I still felt crummy anyways. And then they use again and you lose your shot at it, right? So that's just my counterpoint. Number one, we tend to overtreat a bit, knowing we can always back off later. versus under treating and having them use again. And then also to explain why you might see these higher doses coming into you for follow-up.
Dr. Moore, I totally agree with what you said. So I actually think that the emergency department gets really higher users, right? Like higher amount users. And so I agree that the higher doses are appropriate, right? You're getting a lot of our fentanyl using, our heroin using. And so absolutely. And we've seen very appropriate dosing from Enloe. Sometimes we do end up bringing them down a little bit, but we're been thrilled with the care there. So thank you for that point. We really appreciate it. Any other questions or concerns?
I'm looking at the chat. I haven't seen anybody with a question, but there are some grateful comments made.
This was quite the whirlwind of how to do an induction and outpatient, and I know that it didn't cover everything. I am happy to leave my email and my cell phone in the chat. Really do feel free to call me. Is something that you are capable of doing. And if you want to just run through how you're doing your induction over the phone, I'm happy to talk it through with you. It's no problem.
That's wonderful. So this is recorded. We will be posting it to the Butte-Glenn Medical Society YouTube channel and free to share. It's a public channel, so everybody's welcome to share it. Thank you so much. And thank you to the urology program. Good to hear from you. All right, I guess we should wrap up. And so thank you so much. It's wonderful that you were able to give this presentation. We'll look forward to other virtual grand rounds where we can share even more. And of course, the summit on the 15th of September.